Welcome to this series of interviews with giants in cardiothoracic surgery. My name is Tom Nguyen, and we're here at the SCS in San Diego with Dr. Professor Michael Reardon. Dr. Reardon, you're Professor of Cardiothoracic Surgery at Houston Methodist DeBakey Heart and Vascular Institute. You're also the Allison Family Distinguished Chair of Cardiovascular Research. You have the unique distinction of being trained by two giants in our field, Dr. Michael DeBakey as well as Dr. Denton Cooley. You have a wide range of interests in both thoracic and cardiac surgery, including lung cancer surgery, stem cell research, and more importantly, transcatheter interventions. You serve on the National Steering Committee for the core valve trial, and what's interesting is that as a surgeon, you're the national surgical PI for SURTAVI as well as RIPRISE 3, as well as a local PI for the COAP trial. And it's really your contribution and expertise in transcatheter intervention is what we'd really like to talk to you today about. So firstly, can you describe to us what is TAVR and why is this technology so important?
Well, thanks, Tom. It's great to be able to talk about this today. So TAVR, or transcatheter valve replacement, is a way of replacing something that you and I have done our entire career, and that is replacing the aortic valve in people that have symptomatic severe aortic stenosis, because as we know, they're going to die if we don't replace their valve. There is no medical therapy for it. And unfortunately, some people are too old, too frail, too sick, really to be good candidates for you to operate on and for me to operate on. And so transcatheter approaches have been developed. And we can go up through the groin and put a valve inside your old valve and expand it out, push the old valve out of the way and let a new valve fall into position. Now, there are a variety of ways of doing this and a variety of valves, and that's one of the things that makes it so interesting.
So what kind of patients are eligible for TAVR and what patients are not eligible for TAVR?
Well, there's three broad categories that everybody has to meet to be a candidate for TAVR. One is a level of risk. The other is that you have to have a certain amount of aortic stenosis on your echo. And third, your annulus, or where the valve is going to fit, has to be one of the sizes of valves. These valves don't cover every single size like surgical valves because it's fairly new technology. Risk is kind of the biggest issue right now. We generally think of people as in 4 risk buckets, although it's really just a continuum. And at one end, we have the low-risk patient, a 40-year-old man with nothing wrong with him. He's not going to get a TAVR. We're going to operate on that man. His mortality in your hands is less than 1%, and you have long-term data. I've got my own 32-year data on these people. At the other end of the spectrum is the 90-year-old that comes in that's in a wheelchair on oxygen. You're not going to operate on that person, and I'm not, even without TAVR. And in between, we have high-risk patients and we have intermediate-risk patients. And the high-risk patients and the extreme-risk patients can get commercial TAVRs, and they can get study TAVRs if you're part of a study. The intermediate-risk patient right now only has TAVR available as a study option in the U.S. in a randomized trial against surgery, except for the S3 trial, which is non-randomized, but again, it's still a trial.
You use this term commercial. What does commercial TAVR mean?
Well, commercial TAVR means that it's been approved by the FDA for use. And so that if a patient walks into your office and you evaluate them and they fit all the criteria for TAVR, you can choose one of the 2 commercially available valves as long as your site has been trained in those valves and you're up and ready to use them. Unlike a study where they not only have to meet the criteria, but they generally have to go through other hoops to be part of the study.
And currently, what commercial devices are available for TAVR?
Well, in the U.S., the commercial devices are the SAPIEN XT. It's a cobalt chromium valve with a bovine pericardial valve inside it, so it's balloon expandable, and the core valve, which is a nitinol frame with a porcine valve inside it, so it's a self-expanding valve.
Well, it sounds like really exciting technology. So what are some of the risk factors of having a TAVR implantation?
Well, like anything invasive, it's not without its risk. We have to access your vascular system. In the core valve IDE trial, 83% of the cases we did were transfemoral. It was lower in the partner trial because they had bigger sheaths, but with the XT valve, it's now the same size. And so it's probably about 80% of people are done femorally. If you choose arteries that are too small and aren't cognizant of it, you can damage these arteries. You can puncture these arteries. You can dissect these arteries. You can rupture the heart with a balloon when you put the balloon in there. You can puncture the heart with a wire. Fortunately, all these things are very low risk, particularly in experienced sites, but they're all possibilities.
Well, let's say if I were to give you a magic ball and you were able to really change the technology, if you were to change one thing about the transcatheter valve technology, what would that be? What's the Achilles heel that if you were to be able to fix, that we will get over some of the hurdles that we have with TAVR implantation?
Well, that's a great question. I think let's start off by talking about what really works in TAVR. One thing that works in TAVR, and everybody agrees with, is it always gets rid of aortic stenosis as well as surgical stented valve. Every valve out there, every single time, gets rid of aortic stenosis. And in fact, in the core valve IDE trial, in the randomized trial to surgery, the core valve TAVR had better hemodynamic flow parameters than the surgical valve at every time point in the study, statistically superior. And all these valves work. There was some worry about stroke after partner A. Stroke was actually numerically less in the core valve trial, even though it didn't reach statistical significance. And the literature is now showing us that stroke, it's a problem with both, but it's probably no greater. Most of the other complications are relatively close. There's really two big things we worry about right now. One is paravalvular leak. Unlike surgery where we cut out the valve and sew it in nice and tight, this valve has to sit inside an old calcified valve, and there can be leak around that. And that leak can affect your mortality and your quality of life. And the other issue is durability. Now, the leak I'd like us to fix right now. That's the answer to your question. Right. Durability, only time will tell.
So that if you fix one thing, it would be the paravalvular leak. You think that's the most important intervention to the most important technological advancement for TAVR right now?
Well, I think that's always a hard question because there's so many things I'd like to fix if I was magic. But right now, paravalvular leak is a real issue. We know we get rid of aortic stenosis. If we got rid of paravalvular leak, we would then have a valve that's basically equivalent to the surgical valves, if not better than the surgical valves. And then we'd have to worry about the complications of putting them in, which are getting better with time. And then we'd have to worry about durability. And again, only time will tell that.
You talked a little bit about the various risk profiles for treatment of aortic stenosis, and as we know, patients who are high risk or inoperable, the recent ACC AHA guidelines recommends TAVR for the first time in history. And for patients who are low risk, then surgical AVR is the option. So I'm opposed to this scenario. Let's say your aunt calls you. She's 60 years old. She's relatively healthy. She hasn't had any operations before, and she has severe symptomatic aortic stenosis. And you calculate her STS score to be roughly 5%. You're an expert in the field. Are you going to give her a TAVR or a surgical AVR for intermediate risk?
Well, she clearly falls into the intermediate risk paradigm at 5. That actually would be fairly high for that age group for an STS. If you look at, again, the core valve high risk randomized, our average STS was 7.5, and we had superior survival. If you took those people and divided them into people that had an STS above 7 or an STS below 7, each group that had TAVR had a 30% improvement over surgery, even the low STSs, which then leads one to think about what's going on with the intermediate risk. We're waiting for the PARTNER 2A data. We're very excited. There's some data out of Europe that seems to show that it's going to be equivalent survival. And right now in SURTAVI, the FDA has allowed us to move the entrance criteria on risk to a predicted operative mortality of 3% or above without an STS limit on it. And so this, if that was my aunt, she would fall very clearly into intermediate risk, and I would offer, in my institution, entrance into SURTAVI.
You would. So let's change the scenario a little bit. Let's say your aunt had prior cardiac surgery. She has a patent lima that somewhat crosses midline, and her STS score is now 8.9%. TAVR or surgical AVR?
She's going to get a TAVR. I mean, I think for those of us in the field, there's really no question about that. She's got an STS above 8. She's got a previous CAB. I know in the PARTNER trial that didn't really pan out better for TAVR, but you're going to find out in the core valve trial that it actually does work better. And so I think TAVR in the setting of previous coronary surgery, particularly with a lima at risk, there's very little question in my mind, and I suspect in yours, that you would do a TAVR in that patient.
50-year-old rheumatic aortic stenosis, STS score 3%.
Well, it goes to surgery for two reasons. First of all, it's rheumatic, and TAVR was not tested against rheumatics. It probably would work, but it was tested against calcific aortic degeneration. And second of all, 50 years old. And at a 50-year-old, the real question is going to be, what valve do you put in this patient? Do you put in a mechanical valve or you put in a tissue valve? I think 10 years ago, there would have been no question we put a mechanical valve in. I think there are reasons to consider a tissue valve right now, but it's not something that I recommend in and of itself. I'd sit down and talk with my patient about the pros and cons of both valves, and of course valve and valve does come in there.
What do you see the future of TAVR in patients who are intermediate risk? Do you see us eventually transitioning to TAVRs, or do you think surgical AVR is still going to be a viable option for patients who are pure intermediate risk?
Well, I think there's several answers to that. First of all, if we solve paravalvular leak, which it appears we are with the newer generation of valves, so if you look at the Lotus valve and the Reprise 2, the moderate to severe paravalvular leak rate at a year was 1%. That's as good as surgery, quite frankly. And it gets rid of aortic stenosis as well as surgery. And the risk of putting it in is generally less, particularly if you're doing it transfemoral. And so now we're down to durability. And I think the real key is durability. If these things prove durable, intermediate risk people are going to be getting TAVRs even at younger ages. The problem with durability is that the average age in the partner trial and the core valve trials is over 83 years of age. And the older you are, the slower biologic valves degenerate. So if you do it in people that are 65, it takes 7 to 8 years to generally see a signal of structural valve deterioration. For 83-year-olds, it may take 11 years or 12 years. A lot of 83-year-olds aren't alive at 10, so we probably won't even know until we move into less risk patients.
So we might not find out for another 15, 20 years then. Is that what you're suggesting?
And when we do, we're going to have new valves. So that's going to be a conundrum.
And the technology, as you know, is advancing exponentially. So the technology has only been around for the past 5 to 7 years.
And it's been tested against surgical aortic valve technology that has been very mature, around for 60 years. And right. when I was in the core valve trial, I was doing surgical aortic valves, of which I had 32 years of experience, and TAVRs, of which when I started I had no experience.
So we talked a lot about aortic valve disease and the treatment through transcatheter technology. To what extent has transcatheter intervention extended to the mitral valve?
Well, I think the mitral valve is interesting for a lot of reasons. It has extended there, and there are a lot of people working on it. The only thing approved in the U.S., of course, is the MitraClip as a way of recreating the surgical alveoli stitch. It has shown that it has a survival and safety profile that's equal to surgery, but it doesn't get rid of mitral regurgitation as well. I think as we move further along and consider total mitral valve replacements and even repairs, we have to realize that transcatheter aortic valve and transcatheter mitral interventions are really different. The patients are different. The aortic patients tend to be older, the mitrals tend to be younger. We're treating different diseases. The aortic, we're treating basically only aortic stenosis, although some aortic insufficiency is being treated now. Basically one disease, calcific degenerative aortic stenosis. In mitral disease, we're treating regurgitation. In younger patients, we're treating regurgitation that is primary. We're treating mitral regurgitation, which is functional, broadly different. And when you look at the primary degenerative mitral regurg, it comes in a whole panoply of shapes and sizes. So it's different. And in transcatheter aortic valve replacement, we were replicating an operation and surgery that worked very well, aortic valve replacement. In the mitral valve replacement arena, we're trying to replicate our second line, mitral valve replacement, not our first line repair. The repairs so far have been more difficult and have not really proven as good as surgery at getting rid of MR.
And repair, you're referring to MitraClip.
MitraClip.
And MitraClip is the only FDA-approved commercial device available right now for mitral valve repair. Correct. Is that correct? What patients are eligible for MitraClip?
For MitraClip, it's patients that have severe mitral regurgitation, symptoms, and degenerative or primary mitral regurgitation, so not functional regurgitation. And they have to be non-surgical candidates, high-risk surgical candidates. The problem is that in my practice and your practice, the majority of people that have primary mitral regurgitation are good surgical candidates, and we have a very good operation for it.
What are some of the risks of MitraClip?
Well, you have to access the venous system, not a big deal. You have to cross the septum. You can cross outside the heart. You can have a clip that becomes dislodged, very uncommon. You might not get rid of all of it. And if you put a MitraClip on there and it fails at some point in the future and you have to go take it off, the chance of repairing that valve is not as good as if you had done it de novo.
You talked a little bit about total mitral valve replacement. What's the current status of total mitral valve replacements for our patients?
Well, there's a couple that have had some first-in-mans, but I think the biggest series is about 8 patients right now. And I think in that series, about half the patients died. So right now, it's very nascent. And it's very nascent because the technical aspects of putting it in and the anatomy and the physiology are much different for the mitral than the aortic. In the aortic, you put it in and it's beyond the outflow and it doesn't interfere with the mitral because the mitral and the aortic sit right next to each other. You can actually obstruct the inflow.
Right. So I'm going to give you another crystal ball and a magic wand. If you can have one intervention to really be able to fix the mitral valve through a transcatheter approach, what modification would you do for mitral valve repair? And then similarly, what modification would you do for a mitral valve replacement? Transcatheter mitral valve repair, transcatheter mitral valve replacement.
Well, for repair, if I had a magic way of making it work, it would be artificial cords. I mean, if you look at mitral valve repairs, as long as you have enough pliable leaflets, we can fix almost every one of them by resuspending the valves in the appropriate area with neocords. Now, we generally add a ring to that too, but it's the cords that kind of do the initial repair and the ring stabilizes it. So with the repair, if I had a way of adding neocords appropriately, that's what I would do. If for replacement, I don't think we know the answer to the replacement. One of the real challenges is that we're going to have a valve that really seals. The paravalvular leaks that we see in aortic valve replacement, TAVR, are not going to be as well tolerated in the mitral. They just aren't. We know that from the surgical literature. The hemodynamics are much different. The pressure gradients are much different. And in the mitral area, they tend to grow with time, whereas they tend to be stable with the aortic. So that's going to be a real challenge.
Right. Let's fast forward 10 years from now. You and I are very active with our respective transcatheter programs at our institutions. 10 years from now, will TAVRs and catheter-based mitral procedures be primarily performed by cardiologists or by surgeons?
Well, if I have my way, the surgeons will be deeply involved in this, and I think there's some parallels from history. I'm old enough that when I started, cardiac surgeons did open cardiac surgery and open vascular surgery, and it was one big field because it was all open surgery. And over time, endovascular came around, and we noticed at my institution that all of a sudden cardiologists, interventional radiologists were doing a lot of the peripheral interventions. And I think across the country, vascular surgeons noticed the same thing. When EVAR came along and aneurysms could be repaired with a stent procedure, the vascular surgeons realized that if they didn't learn how to do this, they were going to lose their field. And there was actually a sea change within the field of vascular surgery in the way they approached this, the way they trained people, and they became experts at intervention. And now my hospital, vascular interventions are not done by cardiologists anymore, interventional radiologists, they're done primarily by vascular surgeons. Right. I think TAVR, for you and for me, particularly for guys of your age, right, this is our EVAR moment. This is the time where we need to step forward and make sure that cardiac surgeons take ownership of this and they're not standing in the rear watching somebody else do this.
I like the phrase you use, the EVAR moment. I think it's very, very appropriate and accurate. So right now, TAVRs to be reimbursed by CMS requires participation by both cardiologists and surgeons. Let's say if CMS released that requirement, where do you see the field going?
Well, I'm very worried that in a lot of institutions, it'll be taken over by cardiologists because they won't have a strong-willed surgeon. There aren't that many surgeons that have received the training to do this. And so we're going to have to make sure that we get these surgeons trained up and they can step forward and do this. I think in my institution, your institution, surgeons will be deeply involved no matter what CMS said, because that's what makes a good program.
The last question I want to ask you is, a lot of surgeons out there want to learn transcatheter technology. What's the best way to train cardiac surgeons in transcatheter technology, both aortic and mitral valve?
Well, we're going to start training at the resident level. Our residents and your residents now go in and they get transcatheter experience. But for the surgeon that's already practicing, I started by partnering with my vascular people and scrubbing on every EVAR and TVAR many years ago because I knew that that was going to be the way of the future. And then you go to your cardiologist and you scrub with them on their balloon aortic valvuloplasties. So these start to teach you the wire skills and the catheter skills that are the basis of this.
Dr. Reardon, I want to thank you so much for your time. We think we really benefited from your expertise, your knowledge, and your insight on transcatheter valve. And hopefully there will be some lessons out there for the audience to take home. And I think one of the lessons, as you alluded to, is that surgeons need to be proactive in learning and adopting the technology. And it is an EVAR moment for us. Thank you so much, Dr. Reardon.
Thank you, Tom.